I gave my webinar to the fasting method participants. As you know, every month through the fasting method, I give a webinar. It's an open forum. People ask me question and answers. And sometimes I give a presentation and I forgot to hit the record button. So I'm re-recording that. And the question that I was exploring was, can a high-fat diet be toxic to somebody with insulin resistance? One of the mistakes that the low-carb community can do is to go out and propound that a low-carb diet is beneficial for everyone without qualifications, because there are certain nuances and certain precautions that you need to take before you advocate this to everyone. So in order to evaluate that, I was asking the following questions. Define how insulin resistance controls cholesterol and triglyceride metabolism. What causes high triglycerides? In other words, define what is called lipoprotein insulin resistance. How do we get fatty liver? What is reverse cholesterol transport? And can a low-carb, high-fat diet cause lipotoxicity? Now, it may come as a surprise to some that insulin not only controls carbohydrate metabolism, but also controls all aspects of fat and lipoprotein metabolism as well. So let's start out with the basics. How do we define insulin resistance? Insulin resistance is decreased insulin responsiveness or action at the level of the liver, the muscles, and the adipose tissue cells. When the liver is insulin resistant, there's an increased amount of sugar output or hepatic glucose output. There is an increased amount of triglycerides. That means the liver is exporting fat, and not only is it exporting fat, but it is storing fat and can have non-alcoholic fatty liver disease. The muscles become insulin resistant because they are unable to either use glucose or fat for energy. At the level of our adipose tissue, or here, insulin packs the fat into the fat cells. When somebody is insulin resistant, the fat that you have ingested, you are not able to pack it into the fat cells. Our fat cells are not just filled with fat, but they have other cells around them. Some of them are called pre-adipocytes. These pre-adipocytes can differentiate into new fat cells. There are also blood cells. Principal amongst them is macrophage, which is involved in inflammation. When you take fat tissue and you spin it, the cells go to the bottom except for the fat cells because they have low density and they stay at the top. Now this slide is showing the difference between healthy fat tissue and between fat tissue that is capable of multiplying into additional fat cells versus tissue that is not capable of doing that and becomes hypertrophied and inflamed. Generally, women are blessed with healthier fat tissue, so they can get a little bit heavier without getting inflamed because their fat cells can multiply. One fat cells can multiply into additional fat cells, or pre-adipocytes can differentiate into new fat cells. I don't want to stereotype any sex, but men usually don't have healthy fat tissue. Their fat cells hypertrophy rather than increase in number, and when they hypertrophy, they get inflamed. Some of them die, and there is an increase in the amount of inflammation and inflammatory cells in the fat cells of men. Now let us see how insulin is involved in the metabolism of the adipose tissue or fat tissue. So here is a person who's ingesting fat. it gets processed in the small intestines. It gets packed into a chylomicron molecule. The chylomicron is nothing but a fat-filled globule. It's a kind of a cholesterol molecule that is filled with fat. It circulates in the bloodstream. In other words, it's dumped into the bloodstream directly from our intestine. It circulates in search of a fat cell. It comes to a fat cell, and in the presence of an insulin-sensitive enzyme, which is called lipoprotein lipase, it dumps about 80% of its fat into the adipose tissue and then becomes a chylomicron remnant. Similarly, the liver exports a fat-filled lipoprotein, which is called VLDL. Again, through the action of lipoprotein lipase, it dumps its fat cargo into the fat cells, becomes a remnant, and these two remnants are picked up by the liver and cleared from the circulation. Now, this is depicting it again. This is a chylomicron from ingested fat, lipoprotein lipase. This is a blood vessel that is circulating in and around the fat tissue. With the action of insulin, it is dumping its cargo into the adipose tissue, becomes a remnant cleared by the liver. Now, what happens in the setting of insulin resistance? In the setting of insulin resistance, the chylomicron is unable to dump its fat content into the fat cells because the adipose tissue is resistant to the action of insulin. Lipoprotein lipase does not work. And neither does it work for VLDL. So what happens is that this being unable to dump its fat cargo becomes a larger remnant. A larger remnant meaning that it is filled with fat, and this fat-filled remnants are now cleared by the liver. So the liver, in the setting of insulin resistance, is getting an extra load of fat. Now, is it getting an extra load of fat from the fat cells as well? We already mentioned that the fat tissue is resistant to the action of lipoprotein lipase, so it cannot pack fat into it. But in addition to that, the fat cells are continually releasing fat into the bloodstream for our use. But in the setting of insulin resistance, this lipolysis is uninhibited. In other words, the fat cells are dumping fat into our circulation when it is not needed. So these fatty acids are then picked up in the circulation by albumin. This complex goes to the liver, and there is an increased uptake of fatty acids because of lipolysis in the liver. As if this were not enough, we already mentioned that chylomicron remnants are larger in insulin resistance, so the liver is getting a large amount of fat through that source. The fat cells are just basically leaching fatty acids into the bloodstream, and so the liver is getting more fat through that source. But there is also increased production of fat in the liver. How so? Now, this process is called Denovo lipogenesis, and the ingested carbohydrates are then picked up by the liver, and instead of being burned and stored as glycogen, which we will see in an insulin-sensitive state, the insulin resistance, through several biochemical steps, is increasing the fat manufacturing machinery in the liver. So it takes an ingested carbohydrate and converts it into fat through a process called de novo lipogenesis. So the liver is getting extra fat from three sources. One, from increased lipolysis. The fat cells are basically leaching fat into the circulation. Two, because the fat cells are unable to take the ingested fat through chylomicrons. These chylomicrons are larger, they are cleared by the liver, so the liver is being dumped with more fat. And if that were not enough, the fat manufacturing machinery from carbohydrate is jacked up, and so the liver makes a large amount of its own fat. So what does the liver do with the extra fat? It can either burn it, it can store it as lipid droplets, and these lipid droplets can then, if their increase in number, can cause fatty liver disease, or it can export it as VLDL. So it's exporting triglycerides as fat-filled lipoprotein molecules called VLDL. This is a healthy liver architecture. When you get fatty liver, it shows that there is fat-filled liver on microscope. Fatty liver disease is a spectrum from healthy to inflammation to scar tissue, which is fibrosis, irreversible scar tissue, which is cirrhosis, and then it can progress to hepatocellular cancer. The earlier stages of fatty liver disease are reversible, but perhaps cirrhosis is not. Now, I promised you that I will explain to you what is the action of insulin on the liver in an insulin-sensitive individual in whom insulin is working well. So this person who is ingesting a standard American diet, carbohydrates, but is insulin sensitive, it can take in the carbohydrate and burn it or store it as glycogen. Because somebody is ingesting carbohydrate in an insulin sensitive state, the liver says, hey, we have enough carbs coming in. I don't need to put out carbs. So this process called hepatic glucose output is reduced. In a low carbohydrate state of fasting, somebody is not eating at all or not eating carbs. There are no carbs coming to the liver. So the liver is not going to burn the carbs or store them because it's not getting any. But instead of that, what it's going to do is it's going to make carbs through a process called gluconeogenesis. So it's going to take the glycerol from the fatty acids and going to take amino acids from muscle breakdown, and in the process of converting it into glucose through gluconeogenesis, it increases what is called hepatic glucose output. So in the fasted situation, in a low carb situation, the liver is charged with the responsibility of making glucose for brain use. And that's an important function. But when somebody is eating, that hepatic glucose output should be shut down so that glucose levels don't go up. However, in an insulin resistant state, the action of insulin on carbohydrates in terms of oxidation is reduced, so it cannot burn it. It cannot store it as glycogen. On the other hand, insulin jacks up the machinery for converting it into fat, Denovo lipogenesis, and the extra insulin that is present, because liver is insulin resistant, it is unable to prevent new glucose from being formed. So gluconeogenesis is jacked up. So in other words, an insulin resistant liver, despite the person eating carbohydrates and putting glucose into their bloodstream, the liver continues to make glucose, which is the wrong thing to do in that situation. So how do we tie insulin resistance and fatty liver disease into something called reverse cholesterol transport? Because that's something I promised that I would explore. So this is a blood vessel. So let me kind of take you through that. It's a little complicated slide. This is the outer wall of the blood vessel, the media or the middle wall, and then there is a lining of endothelial cells. This is one wall, this is the opposing wall, this is the lumen out here. And all of us, with aging, with high blood pressure, with stress, are going to get vessel injury. So this vessel is injured, and there is denudation of the lining or the endothelium. When there is damage, the LDL, in my opinion, comes to repair that damage. I have a YouTube video out which is called "Is Oxidized LDL an Injured Firefighter or an Arsonist?" It is worth a view, and I would like you to go review that subject there because I'm not going to cover it out here. Suffice it to say that LDL has many antioxidants. It comes here to heal the oxidative damage, the free radicals or the oxygen radicals that cause oxidative injury. And in the process, the LDL, while it's healing, gets oxidized. This oxidized LDL can no longer be picked up by the liver. It's picked up by cells in our media and adventitia, and these are called macrophages. So the macrophages ingest this LDL, which is oxidized LDL, because it's done its function, it's damaged, and these are clearing mechanisms of the body. Now, in a normal setting, the macrophages have mechanisms for effluxing the cholesterol. They can remove the cholesterol through a process called reverse cholesterol transport. Not only does it happen at the level of the macrophages, but it happens in every cell, especially in somebody who's fasting and is having autophagy. But perhaps vascular reverse cholesterol transport is most important. So there is export or efflux of cholesterol to a waiting HDL molecule. The HDL molecule undergoes maturation by esterifying the cholesterol. In other words, to the cholesterol, a fatty acid is added. That's called esterification. That is done through an enzyme called LCAT, lysolecithin cholesterol acetyltransferase. And then after that is done, the HDL becomes larger. It's called large HDL2. And this large HDL2 can either go directly to the liver and dump its cholesterol content. The lipoprotein or the apoprotein of HDL, ApoA1, is recycled for further cholesterol transport. However, this is perhaps not as important as the other branch of cholesterol transport, in which the HDL molecule is dumping its cholesterol cargo into an LDL molecule. So LDL, which many people call as the bad cholesterol, I would like to call it the other good cholesterol, is involved in reverse cholesterol transport, perhaps more than HDL alone. This is happening through an enzyme called cholesterol ester transfer protein, that is CETP. This is mislabeled out here. Because in a healthy individual, the triglyceride-rich lipoprotein, so the fat in bloodstream is low, this process does not happen. When I meant this process does not happen, I mean there is not a transfer of cholesterol to the triglyceride-rich lipoproteins. But the question that we were trying to explore is that how do high triglycerides reduce reverse cholesterol transport? And the mechanism for that is that as the HDL molecule matures, the high triglycerides are favored by the cholesterol ester transfer protein, and instead of reverse cholesterol transport going to the liver, it goes to the triglycerides. And when it goes to the triglycerides, the apolipoprotein, or the protein of the HDL, is then subsequently destroyed by proteases. So in other words, it interrupts the recycling of HDL and it interrupts the reverse cholesterol transport. So one of the best ways to remove reverse cholesterol transport, or to inhibit or reduce reverse cholesterol transport, is to have high triglycerides in the setting of insulin resistance. And these high triglycerides are unable to dump their cargo into the fat cells. They will then find a suitable organ like the liver, cause fatty liver disease, or go to the pancreas and cause fatty pancreas with additional damage. So I'm very nerdy and I put all kinds of explanations, and for people who are really interested, they can look up all this different stuff that I have written out here. But I put this slide up to remind my audience and to remind myself that I have written a book chapter in the textbook of low carb medicine with regards to cholesterol. And this is one of the figures that I'm going to put in there, that there is compromise in reverse cholesterol transport in metabolic syndrome and possibly with statins and PCSK9 inhibitors. I've already told you how metabolic syndrome causes that. Let me take you and explain to you how statins and PCSK9 inhibitors do that. So, when you inhibit reverse cholesterol transport, you form foam cells. In other words, the macrophages keep ingesting oxidized LDL, but they are unable to efflux it. So this is a concept that I'm explaining before I talk about statins and PCSK9 inhibitors as to how they inhibit reverse cholesterol transport. When you inhibit reverse cholesterol transport, you form foam cells. These are fat-filled, cholesterol-filled macrophages in the blood vessel wall. And when they get sufficiently full, they rupture. And when they rupture, they release its fat content into the blood vessel that incites a blood clot and platelets and fibrin. And when this blood clot goes to completion, it occludes the blood vessel and causes either a stroke or a heart attack. So you want robust reverse cholesterol transport in order to prevent vascular events. So what's the mechanism by which statins and PCSK9 inhibitors reduce reverse cholesterol transport? As you know, the statins reduce the LDL perhaps by up to 50%. The PCSK9 inhibitors reduce it to as much as 70%. There are trials in which the LDL has gone down to 30 milligrams per deciliter in the PCSK9 inhibitor trials. When you reduce LDL that dramatically, you reduce reverse cholesterol transport to the liver. So here is a situation in which people have metabolic syndrome versus control. This is a study. And there are three components to the metabolic syndrome. One is high triglycerides. Second is high levels of small dense LDL. In other words, even though the LDL level doesn't change, the small dense LDL goes up. And the third component is reduced HDL. So the small dense LDL is larger in metabolic syndrome people. The HDL2, which is the more mature form of HDL, is lower. And these are biochemical markers. This is another biochemical marker. HDL2 is a more mature form compared to HDL3, and we are looking at the ratio here. So as the components of metabolic syndrome increase, in other words, presence of hypertension, obesity or waist circumference, high triglycerides, low HDL, hypertension, high blood pressure, as the components increase, the amount of mature LDL falls, indicating that there is reduced reverse cholesterol transport. So this is a study in which they compared patients with established coronary artery disease. So these people had evidence of calcium in their blood vessels, or blockages. These are controls. And as you can see out here, the triglycerides were higher in cases than in controls. The mature form of HDL was lower in patients with heart disease compared to controls. The LDL cholesterol was not very different. But the reason I put this slide up is for this particular reason. There is a reduced clearance of ingested fat in people with metabolic syndrome and coronary artery disease. So in this coronary artery disease population that had underlying metabolic syndrome, fat is ingested, and compared to controls, the fat levels remain high at 4, 6, and 8 hours compared to the controls, indicating that there is presence of triglycerides or presence of fat in your bloodstream because you are unable to dump the fat into the fat cells. So people have attempted to meddle with reverse cholesterol transport. This is one of the slides that I had used in which it says that when people are undergoing autophagy, when cells are undergoing autophagy, the apolipoprotein of HDL picks up the cholesterol from the cells and then takes it to the LDL. So this is the HDL that is matured. The HDL is then transferring the cholesterol to the LDL, and the LDL then is causing reverse cholesterol transport. And I think this is just animation that's showing the HDL giving cholesterol to the LDL then giving cholesterol back to the liver in a process which is called reverse cholesterol transport. The cholesterol and the lipoproteins in the LDL are then recycled along with the LDL receptor by the liver. So a study was done which is called the Illuminate trial, and they said that high HDL in the bloodstream is beneficial. And we should produce high HDL by inhibiting cholesterol ester transfer protein. In other words, the transfer of cholesterol from HDL to LDL. And I'll tell you why this is important in the cases of statins and PCSK9 inhibitors. So to this group of people, they gave them that CETP inhibitor, and in these people the HDL was much higher, 83 compared to 49. The LDL cholesterol was much lower. So a traditional physician who is trained in lipoproteins would say, he would salivate. He'd say, Mr. So-and-so, you are immune from heart disease now because your HDL is high and your LDL is low. So basically, you're not going to get heart disease. So what happened in this trial? So what happened in this trial was that the administration of this drug, this trial, by the way, Illuminate trial, was stopped early because of increased mortality. There was an increase in death. There was an increase in cancer mortality. There was an increase in infections and increase in strokes. The reason is because you made the HDL molecule dysfunctional. One of the important ways in which reverse cholesterol transport happens is by transferring the cholesterol in the HDL to the LDL to aid with the reverse cholesterol transport. And statins and PCSK9 inhibitors do exactly the same, perhaps not in as graphic a way as CETP inhibitors do. So a low carbohydrate, high fat diet in patients with insulin resistance and high triglycerides is not correct because one size does not fit all in terms of dietary recommendations. So the question that comes about is, should we recommend this type of a diet to people with insulin resistance who have high triglycerides? Is there danger of lipotoxicity? Can you exacerbate fatty liver disease? Can you make the non-alcoholic fatty liver disease worse? Can you reduce reverse cholesterol transport in these individuals? Is it possible for you to worsen plaque and increase the risks of strokes and heart attacks in these individuals? Perhaps the answer to that is yes. And I am not suggesting by any means that we should ask these people to take a high carb, low fat diet, because that's only going to make insulin resistance worse. It's going to make Denovo lipogenesis worse. What I'm suggesting is that we should have an initial focus on intermittent and long-term fasting, because this way you are promoting insulin sensitivity, you are reducing insulin levels and insulin resistance, that you should advise them to exercise that is optimized to recovery. Now, what does that mean? I have a YouTube video out that talks about how you can tailor the exercise to optimal recovery. This is called my heart rate variability video, and you should look into that. So what diet should be advised to these individuals? The diet that should be advised is a low carbohydrate and low fat. And when you talk about a low carbohydrate, low fat diet, it's an oxymoron. So this is really, when you reduce the carbs, you increase the fat. A low carb, low fat diet is not sustainable because it's basically a lean protein diet. There is calorie restriction with that because you cannot eat enough protein for your caloric needs. So you're actually eating less, but you are mobilizing fat from your fat cells and you are emptying your fat cells so that you can pack the fat cells with the fat that you are ingesting when you start ingesting fat. So I propose that this regimen should be followed until the triglycerides are below 100 and the HDL is greater than 50 to 60 in people with insulin resistance and high triglycerides. So that's all I had, and I wish and I hope that you liked this presentation, that it makes common sense, that there is scientific validity based on all this information that I gave you. And I would also like to promote our webinar through the fasting method. I would like you to join. You would just have to log on to the fasting method to sign up for the webinar, and that webinar happens on the last Wednesday of every month at 6 p.m. Central Standard Time. Thank you.